what if the exact medical procedure that's marketed to basically fix your intimacy and, make you feel like yourself again,
Right.
what if that is the very thing that leaves you in excruciating long-term pain?
It's it's a massive blind spot. And today we are looking at this deeply concerning collision.
Yeah.
Because on one side, you have this huge commercial trend pushing lasers and, well, surgical tightening. And then on the other side, you have a really complex, wildly misunderstood muscular condition called vaginismus.
And going through our stack of sources for today's deep dive, I mean, we've got medical guidelines from the UK's National Institute for Health and Care Excellence, or we've got FDA warnings on energy-based devices, physical therapy literature.
Yeah, a lot of really heavy clinical data.
Exactly, and a very clear, frankly, kind of alarming picture starts to emerge here. People are basically treating a symptom without verifying the mechanism, and it is completely backfiring.
They are. They're treating a really complex nervous system response with what is essentially a cosmetic structural fix.
Right. So we are inviting you, the listener, to kind of step past all that marketing jargon today. Because if you have ever felt overwhelmed by, like, ads for intimate wellness,
Yeah.
or if you just want to understand the profound mechanics of the pelvic floor, we're going to look under the hood.
There is a massive aha moment waiting here about how your muscles and your nervous system actually interact.
Yeah. So to really understand how this collision happens, we have to start by separating the structure of the tissue from the action of the muscle underneath it.
Absolutely.
And when I was reading the clinical descriptions, the best way I could visualize this difference was thinking about a room.
Oh, I like that analogy.
Yeah, so think of the vagina like a room. Vaginal tightening, whether you're using surgery or a laser device, that's like altering the wallpaper and maybe shrinking the doorway frame.
Right.
But vaginismus is the security system just aggressively slamming the door shut entirely.
That is exactly it. Because changing the wallpaper does absolutely nothing if the alarm system is triggered.
So let's look at the wallpaper side first. The structural tightening.
The stuff that the industry is really pushing.
Yeah. And the industry generally uses two pathways here. There's the surgical route, like a vaginoplasty, which involves a surgeon literally cutting, shortening, and, stitching loose ligaments and tissue to physically create tension.
Right.
And then there are the non-surgical ones, the energy-based devices, or EBDs.
Which is where the market is absolutely exploding right now. I mean,
Yeah.
we were talking about radiofrequency wands and fractional CO2 or ERYH lasers.
Yes, and the mechanism of those lasers is entirely thermal. They literally heat the targeted vaginal tissue up to a very specific window. Usually it's between 40 and 45 degrees Celsius.
Which, just biologically speaking, is an intense amount of heat.
Yeah.
Like you are intentionally causing a thermal injury to the tissue.
Exactly. The clinical goal there is to denature the collagen.
Because when you heat collagen fibers to that level, their triple helix structure actually folds in on itself. They contract. And that folding creates these thicker, much shorter fibers.
Which causes the immediate tissue tightening.
Right. And then, ideally, the body's natural healing response kicks in and theoretically produces new collagen over time.
Okay, so that is the changing wallpaper part. We are heating tissue, shrinking fibers, basically altering the passive architecture.
Exactly.
But then we have the slam door, vaginismus. And medically, the sources call it a genitopelvic pain and penetration disorder. But mechanically, it's an involuntary muscle spasm, right?
Right. Specifically in the pelvic floor muscles, like the luiter ani or the puborectalis. So when a patient anticipates penetration of literally any kind, whether it's intercourse, a medical exam, or, even just a tampon,
Yeah.
these muscles automatically clamp down. It's an active state of hypertonicity.
Hypertonicity.
Yeah, the muscles are literally too tight, they're unable to relax, and they're locked into this fear-tension-pain cycle.
So the brain anticipates the pain, the muscles tense up to protect the body, and then that tension causes actual physical pain during penetration.
Which then completely validates the brain's initial fear.
Right. The cycle just reinforces itself. But, looking at these clinic websites, if a patient goes in and says they feel loose or they feel a lack of friction, the marketing tells you, well, fixing the structure fixes the feeling.
Yes, they do.
It seems sort of logical that shrinking that collagen or doing a surgery, it would automatically make things better. Why doesn't it?
Because that assumption treats muscle tone as just one static thing. And it's not. Muscle tone actually has two completely different components.
Okay.
There's the passive part, which is the physical viscoelastic stiffness of the tissue itself, the wallpaper. But then there's the active part, which is the electrical muscle activity.
Oh, wow.
Yeah. And we can actually measure that electrical current with an electromyography or EMG machine.
So if a patient has vaginismus, they have this abnormal electrical activity that's causing that spasm.
Exactly. So tightening the passive tissue does absolutely nothing to calm down an electrically overactive muscle. In fact, it's worse than doing nothing.
Because if you take a muscle that is already inflamed and exhausted and spasming, and you apply a thermal injury to it with a 45-degree laser.
You are adding trauma to a system that is already incredibly hyperreactive.
Yeah.
And, I mean, this isn't just some theoretical concern.
Right. The sources explicitly warn about this. They say tightening surgery is not a primary treatment for chronic pelvic pain or vaginismus, and that it can actually severely worsen the discomfort if you don't address the root issue.
Yeah. And if you look at the NICE guidelines, they compiled this big overview of transvaginal laser therapy. The adverse events they documented reveal a really terrifying pattern.
It's not just a lack of results, it is active harm.
Yes.
Reading through those case studies, what really shocked me was how quickly the interventions escalated the patient's pain. You had women going in for maybe mild discomfort, a little pain during sex, and they're walking out with severe active muscle spasms.
Like case 2 in the NICE guidelines. There was a patient who underwent a laser treatment for mild painful sex dyspareunia. And the pain progressively worsened until her pelvic floor was in a state of severe hypertonus. She was having intense spasms shooting through both her levator and vaginal muscles.
Wait, really? Just from trying to treat mild pain?
Yes. And the damage isn't always just muscular either. Case 3 showed a patient who developed a crescent-shaped fibrous band right in the middle of her vagina after laser therapy.
Oh, my God.
The laser literally created a scar tissue barricade that partially obstructed the area, creating a stricture.
Making penetration physically impossible without severe pain?
Exactly. And we also see the danger of cumulative trauma. In case 4, a woman with a history of previous pelvic surgeries sought laser treatment, and the resulting trauma from the laser caused her levator antispasms to just skyrocket. Intercourse became severely painful.
So why is the body reacting this way? Like, what is actually happening on a neurological level when that laser hits the tissue?
It ties directly back to that fear, tension, pain cycle we talked about. You know, the pelvic floor is incredibly reactive to threats.
Right.
It's basically one of the first areas of the body to physically tighten in a fight or flight response.
Oh, that makes sense.
Yeah, so when you introduce a 45-degree heat wand, an ablative laser, or, surgical incisions, the nervous system perceives that as a major traumatic event.
Because you are purposefully injuring the tissue to force it to rebuild.
Exactly. Now, for a totally healthy pelvic floor, that controlled trauma heals nicely. But if you already have underlying vaginismus, the unexpected pain or heat triggers a massive protective spasm.
The brain literally screams that the body is under attack.
Yes, and it clenches those muscles even harder, which just deeply reinforces the vaginismus.
The confusion, though, for a lot of people reading these clinic websites is that these fractional lasers are frequently advertised as a treatment for painful sex, especially for postmenopausal women.
They are.
So how can the exact same device that treats pain also cause it?
It comes down to the source of the pain. The pain that these lasers are actually designed to treat is caused by atrophy.
Okay, atrophy.
Right. So during menopause, as estrogen levels drop, the vaginal tissue becomes thin, it gets dry, pale, and inelastic. It lacks blood flow. So the laser creates these micro-injuries that stimulate blood flow and force the tissue to remodel itself into something thicker and more elastic.
So the laser is treating a tissue problem, a passive structural problem caused by lack of hormones.
Exactly. But pain from vaginismus is caused by muscle hypertonicity. It's an active cramp.
Right.
If you take a muscle that is locked in a painful cramp and you zap the overlying tissue with a laser, you aren't fixing the cramp. You're actually creating mechanical allodynia in the area.
Mechanical allodynia, meaning like a light touch or normal friction that normally shouldn't hurt suddenly feels agonizing.
Yes, you are basically layering hypersensitive nerve pain on top of an already exhausted spasming muscle.
So, if heat and scalpels are so clearly triggering the alarm system, why are patients with muscle spasms getting these tissue-tightening treatments in the first place?
So it comes down to the trap of self-diagnosis, the overlap of symptoms, and honestly, extremely persuasive cosmetic marketing.
It really is like taking cough medicine when you actually have acid reflux. I mean, the symptom, the coughing, looks exactly the same to the person experiencing it,
Right.
but the mechanism is entirely different. So the treatment just completely misses the real issue.
Yeah, and the clinical literature points out how easily these overlapping symptoms confuse both patients and, unfortunately, some practitioners too.
Yeah.
Let's say a patient feels a physical looseness or maybe a loss of sensation. Naturally, they look at the marketing, they look at their symptoms, and they assume, oh, I need to be tightened.
Makes sense on the surface.
But the sources note that hypertonic, overly tight pelvic floor muscles often have incredibly poor motor power.
See, this is the part of the research that completely stopped me. The idea that a tight muscle functionally presents as weakness or looseness, it feels like a paradox.
I know, but think about the mechanics of a muscle. A healthy muscle rests in a totally relaxed state, and then when you need it to contract, it has a full range of motion to tighten and grip.
Right.
But if a muscle is locked in a constant, hypertonic state of contraction, it has no range of motion left. It is exhausted. It literally cannot contract any further to grip during intercourse.
And so the patient experiences this lack of grip as weakness. They feel loose, and they assume the solution is to tighten the structure.
Exactly. So they go in for a tightening procedure. They add trauma to a muscle that is already exhausted and spasming, and the entire system just crashes.
Wow.
And conversely, you might have a patient who finds they suddenly can't insert a tampon. They assume their anatomy is structurally too tight and that they need a surgical intervention to open things up.
When in reality, it isn't a structural issue at all. It's that involuntary muscle spasm blocking the entrance. It's the security system slamming the door.
Right, and this widespread confusion is exactly why the FDA has actually issued warnings about the deceptive marketing of vaginal rejuvenation.
Yeah, they emphasize that these devices are not just catch-all magic wands for intimate wellness. A thorough clinical assessment is absolutely required.
You can't just diagnose this from a checklist on a spa's website.
Yeah.
The consensus across all the medical sources is that a clinician-led assessment is vital.
What does that actually look like, though? For the listener, how do they know what they actually need?
It means using validated questionnaires and, most importantly, an actual physical exam to test for pelvic floor hypertonicity versus hypotonicity.
Like, is the muscle too tight or is it actually too loose?
Exactly. And they also have to rule out underlying conditions, things like pelvic organ prolapse or a skin condition called lichen sclerosis, before anyone even touches an energy-based device or a scalpel.
Okay, so if heat and scalpels are out because they trigger the alarm system, how do we actually get the alarm to turn off? Like, if the root cause is vaginismus, what do the sources say actually works to reverse it?
So treating vaginismus isn't about adding energy or cutting tissue. It's about subtraction.
Subtraction.
Yeah, removing the fear and removing the tension. It requires a multidisciplinary, evidence-based approach. And the frontline treatment here is pelvic floor physical therapy.
And reading the physical therapy literature, this is definitely not about doing Kegels.
Oh, absolutely not.
I mean, strengthening the muscle seems like the very last thing you would want to do to a muscle that is locked in a spasm.
Kegels would make it significantly worse. The therapy actually focuses on something called down training.
Down training.
Yes. The physical therapist uses manual myofascial release, which involves specialized internal and external massage techniques to physically relax the muscle knots. And they often pair this with EMG biofeedback.
Yeah, this biofeedback mechanism is fascinating. They place sensors that measure the electrical activity in the muscles, and the patient actually watches the real-time data on a screen.
It is profound for the patient because they can physically see their own tension. They watch the graph spike when they're unconsciously clenching.
Right.
And then the therapist teaches them how to consciously, voluntarily relax those specific pelvic muscles, and they can watch the graph go down. It restores that brain-muscle connection that the fear-tension-pain cycle severed.
The physical therapy sources also heavily emphasize the use of vaginal dilators or trainers as part of this unwinding process.
Yes, dilators are crucial. They're a set of smooth cylinders that graduate in size, and the patient starts with the absolute smallest one, entirely at their own pace.
Usually in a very relaxed, safe environment at home, right?
Exactly. And the goal isn't to stretch the tissue physically. It's not about making the room bigger.
It's exposure therapy for the nervous system.
That's a great way to put it. It teaches the nervous system that penetration can happen without triggering pain or a threat response.
But what about really severe cases, like where the spasms are so locked that physical therapy is simply too painful to even begin?
For those cases, the sources outline medical interventions like Botox.
Which is wild. We usually associate botulinum toxin with, like, freezing wrinkles on a forehead. Using it for a pelvic pain disorder sounds extreme, but the mechanics make total sense.
It really does because it blocks nerve signaling. A specialist will inject Botox directly into the trigger points of the levator ani muscles, and this basically forces the muscle to chemically relax.
Right.
Now, Botox doesn't cure the vaginismus on its own, but it creates a critical therapeutic window.
It hits the pause button on the alarm system.
Exactly. It forcibly stops the spasm long enough for the patient to comfortably engage in the physical therapy and the dilator work.
So you can actually do the rewiring.
Yeah. And the final piece of that rewiring is addressing the psychological side with cognitive behavioral therapy, or CBT.
Because it's not just physical.
Right. CBT gets right to the root of that fear avoidance cycle. We talked about how the brain anticipates pain, which tightens the muscles, which then causes the pain.
Yeah.
CBT helps patients neurologically reframe their anxiety around intimacy. By dismantling the psychological anticipation of pain, the physical muscles literally receive fewer signals to clench.
That's incredible.
The data here is striking, too. The sources note that psychological interventions like CBT can reduce sexual pain by 50% all on their own.
Listening to all of this, the physical therapy, the biofeedback, the dilators, the CBT, it is a massive, intentional unlearning process.
It really is.
And it sounds like it takes a while. It's a stark contrast to the marketing for a laser treatment that boasts like 5-minute sessions on your lunch break.
Well, that is the immense allure of those energy-based devices.
Yeah.
Quick structural fixes are just a really easy sell.
Yeah.
Unwinding vaginismus requires patience because you are fundamentally reprogramming a neurological reflex.
But the results are there.
Right. Oh, totally. The data is incredibly encouraging. Up to 80% of women see major improvements after just an 8-week course of pelvic floor physical therapy.
8 weeks for an 80% success rate? I mean, when you consider you are entirely rewiring a deeply ingrained reflex, that is incredibly fast.
Retraining the nervous system is highly effective when you actually target the correct mechanism.
So let's bring this all back to the broader picture. Vaginal tightening procedures, whether we're talking about fractional lasers, radiofrequency wands, or surgical reconstruction, they are fundamentally designed to build collagen or alter the passive structure of your tissue.
They're just changing the wallpaper.
Right. But if your underlying issue is vaginismus, if the active electrical muscles of your pelvic floor are locked in a hypertonic spasm, the thermal trauma and physical restriction of a tightening procedure won't fix it.
It will violently trigger it.
Or drastically worsen that fear, tension, pain cycle. So if there is one thing for you to take away from this research, it is that treating a symptom without verifying the underlying mechanism is a dangerous guessing game. Knowing the difference between tissue laxity and a muscle spasm empowers you to step back from the marketing and, honestly, demand a proper holistic diagnosis.
Absolutely. You know, we live in a world heavily focused on external aesthetics and this perceived physical perfection of our bodies, which now, unfortunately, extends even to our most intimate parts.
Yeah, the pressure is just relentless.
It really is. And it makes you wonder, could it be that the intense societal pressure driving the marketing of vaginal rejuvenation, this constant heavy messaging that bodies need to be tighter, structurally perfect, and forever youthful, is actively contributing to the psychological anxiety and the physical muscle tension that causes conditions like vaginismus in the first place?
Wow, something to really think about.